Welcome to the UNCG MSAT Continuing Education Module on Evidence-Based Practice. This is Part 9, Evidence-Based Practice at the Elbow. Please complete all 10 parts in the quiz that follows to receive your CEU. Let's begin. In the previous part, we showed how current evidence is showing that the facility test at the knee may be better than some of our classic meniscus tests that we have used in the past, such as McMurray's and Apley's. In this section, we're going to be looking at a similar approach. Looking at UCL or MCL evaluation at the elbow, one of the classic tests that we've always done is the static valgus test for laxity and for pain. You notice that when you do the static valgus test, sensitivity values are not very good at 19 and 65%. You notice that the sensitivity value is extremely poor when looking at laxity. If you remember from section 1, sensitivity means that if it's negative, we can rule the condition out, which is telling us that if you do not have laxity doing a static valgus test, you really have no confidence in saying that the ligament is not torn. We are showing the students a test called the moving valgus test, which is basically putting the patient in 90 degrees of abduction, external rotation, and applying the valgus force as we extend the elbow. You notice that in this case, 100% sensitivity was noted. Now, there might be some limitations in this study, which you can look up with the reference here. One of the big ones being that it is a very small sample size with only 17 patients being looked at. However, 17% of the patients who did not have a positive moving valgus test did not have an actual torn UCL. That is unbelievably high sensitivity. Comparing this to MRI and arthroscopic valgus stress testing is even more ridiculously impressive, where we have the 17 for 17 100 sensitivity value compared to an MRI, which has a 40% sensitivity value. What this means is that even an MRI that comes up clean or comes up negative, you're only 40% confident in saying that they actually do not have a torn UCL. Now, this might be a little bit awkward and hard to swallow for some clinicians. I know the first time I read it, I was really skeptical. And again, when we look at evidence-based practice, we take the clinician, the patient preference, and the best evidence available to formulate a clinical decision. We teach our students not to just use the moving valgus as the one gold standard, but we want them to look at it critically as maybe this is a very good test to put into their repertoire and use when examining the elbow, in addition to history, observation, strength testing, etc. In the next section, we'll be going over our final body part, looking at the shoulder.